I'll let you introduce yourself. Javel, if you're, yeah, recording's on. Okay, great.
All right. Well, hello. It's just seniors, I think, at this point, right? Um, cool. Well, my talk is on chronic inflammatory arthritis. And I say for the PCP because it's really meant not to be a talk for people who want to go into rheumatology, but more so focused on diagnosing patients with potentially chronic inflammatory arthritic illnesses in our primary care setting. I have no conflicts of interest to disclose. And these are my learning objectives. So today we're going to try and develop a framework for approaching a patient with arthritic pain, understand how to differentiate between chronic mechanical and inflammatory arthritis, and review common etiologies of chronic inflammatory arthritis. And then we'll end by reviewing necessary screenings and monitorings that can be done in a PCP's office. In my current view, John, I can't see the chat. So if folks have questions, maybe people can either shout them out or you could just tell me.
Yeah, we'll try to monitor that, but I
Okay,
think it's a small enough group that go ahead and feel free to just yell them out.
awesome. All right, so here's some common etiologies of inflammatory arthritis. Most people are familiar with all of these: rheumatoid arthritis, lupus, and then the spondyloarthropathies. I think people are a little less comfortable with. So that's things like ankylosing spondylitis, psoriatic arthritis, reactive arthritis, and arthritis that's associated with inflammatory bowel disease. And then you have your infectious or septic arthritis and gout and pseudogout. We're really going to focus on the top three today. I think more people feel comfortable diagnosing a septic joint or gout in the clinic than they do diagnosing lupus. So we'll start with a case, and I'm wondering if we could pull up a poll. This is a 58-year-old man with a past medical history of psoriatic arthritis on methotrexate, who's presenting for 3 days of severe right knee pain. He denies fevers, chills, or any trauma, and no other joints are affected. Vitals are stable. On exam, he has psoriatic plaques on his elbows and back, and his right knee is tender, swollen, and warm. Range of motion is significantly limited by his pain. What's the next test you'd like to order? And it may be that you want to order all of them, but if you could just pick one. Awesome. So most people got this one, an arthrocentesis, that is correct. Some people wanted inflammatory markers and a uric acid level, totally reasonable. It sounds like maybe there was some concern for gout. A knee x-ray, I think that could be really useful if there was any history of trauma. I think we'll talk a little bit about approaching a patient with an acute monoarthritis like this, but arthrocentesis is the right answer. So you get your arthrocentesis, and here's what you see. A synovial fluid analysis shows you a white count of 40,000 with 80% neutrophils. Crystal analysis is, of course, pending. So far, you have a negative gram stain, and cultures are pending. At this point, what is the most likely diagnosis? If we could launch another poll, that'd be great. Awesome.
You guys can't see it because as the poll answers are coming in, it's like a two-way race.
I love that.
Oh, and now there's a late third entry.
Awesome. Okay. So most people thought this was a psoriatic arthritis flare. Some people thought septic arthritis. Okay. And then there was maybe a few people who thought gout. Okay, awesome. So The people who thought gout actually got it right. This is a tricky question. So this patient has psoriatic arthritis that seems to be pretty well managed actually on methotrexate, given that none of his other joints are affected. He's coming in with an acute monoarthritis, so 3 days of severe pain in just one joint. It's tender, swollen, extremely, having a lot of kind of inflammatory looking symptoms, and range of motion is significantly limited. Psoriatic arthritis flares, for the folks who chose those, tend to be a little bit more insidious and a little less severe than this. And it would be unusual for someone to present with just one joint affected from a psoriatic flare that's this severe. Unfortunately, people who have psoriasis actually are at significantly higher risk of gout. So people with psoriasis without arthritis are actually 3 times more likely than the general population. And then a patient who already has psoriatic arthritis is like 5 times more likely to have a gout flare. So if you have a patient in your clinic who has a history of psoriasis and is coming in with this like acute monoarthritis, really keep gout on your differential. The folks who said septic arthritis, great, I love it. That is always extremely important to rule out. Usually with those folks, you'll see fevers, and then the synovial fluid analysis will show a white count between classically 50 to 100,000, but it's never perfect. And the gram stain being negative, it's like negative 50% of the times. So it doesn't help you all that much. So I think septic arthritis is a totally reasonable answer as well. All right, so we're going to talk about a framework for approaching a patient with arthritic pain that can
Sorry,
hopefully.
so there's a question about
Yeah.
low-level inflammatory, would synovial fluid analysis look similar, like low-level inflammatory for psoriatic/RA flare?
Yeah, it can generally for like a low-level inflammatory psoriatic or RA flare, you would see multiple joints affected. It's not perfect, but yes, you can see like low levels of white blood cell counts, usually like in the like 2,000, 10,000 to 50,000 range, but it usually doesn't cross that amount. Awesome, thanks. Oh, and I found out how to pull up the chat, so hopefully I can help monitor. So let's talk about a framework for approaching a patient with arthritic pain. There's a lot of different ways to do this. So you can either do it by counting up joints. So one, few, or many is one way to do it. Acute versus chronic. So this patient was very acute, and then looking for signs of inflammation versus mechanical arthritis, which we'll get into. And then the last way to do it is to look at joint distribution. So if you approach it joint-based, this can be super helpful in areas where multiple arthritides are affecting the same area and there's a lot of overlap. So classically, the DIP joints, which are the joints of your fingers just below your nails, are affected by OA or osteoarthritis, psoriatic arthritis, and then the PIP joints are affected by many arthritides. So it's a little less specific if you see a patient with PIP joint arthritis. And then the MCPs are the territory of rheumatoid arthritis and pseudogout. The first CMC joint in your thumb is also affected by osteoarthritis. You use your thumb a lot during your life, and it's prone to degenerative disease. Another way to do it, I'm not going to go through this whole diagram, but is to approach it by number of joints. So 1 is monoarthritis, 2 to 4 would be oligoarthritis, and 5+ would be polyarthritis. This schema is not perfect because autoimmune diseases don't follow the rules, but in general, you can kind of help to narrow the differential. And in our patient who had acute inflammatory arthritis of one joint, based on the schema, you can quickly narrow your differential to crystals and septic arthritis. And then your next step, I think, is a little more obvious there, that if those are your 2 differentials, and arthrocentesis is really what's going to help you differentiate. I just want to point out that osteoarthritis is the main differential you should be thinking of in someone who's coming to you with chronic mechanical arthritic pain, whether it's one joint or many joints. And then this is really what we're going to focus on today, is the chronic inflammatory arthritides. So let's talk about how to differentiate between chronic mechanical and inflammatory arthritis. You're obviously going to start off with the history. So we talked about getting time course, joints, which joints, number of joints. I'm sure you all remember from med school the signs and symptoms of inflammation, the cardinal signs of pain, swelling, warmth, redness, loss of function. And I added on to that morning stiffness because that can be particularly helpful when we do a joint exam. One thing that I'll say is not helpful out of these is pain, because the patient's coming to you with pain. That's why they're there. So I'm going to just cross that out. That's not a helpful symptom in terms of differentiating what's causing this. Swelling is actually incredibly helpful. It's not enough for a patient to come in and say, I have pain. And then when you push on it, they're like, oh yeah, that really hurts. Because of course it does. And I think what you really need to see to differentiate inflammatory arthritis is swelling. So they need to describe that to you, or you need to actually see it on exam. And then warmth and redness, I would say, less helpful. You can get that classically in gout or septic arthritis, but in more insidious processes like lupus, psoriatic arthritis, you may not actually see like a red, hot, warm joint. The swelling will be more useful. And then morning stiffness is an incredibly helpful symptom for differentiating inflammatory arthritis. I was thinking when I came up with this talk about how you ask the question of morning stiffness. Because if you ask your patient, are you stiff in the morning? Of course, they're going to say yes, because it doesn't feel good to wake up with pain and then have to start your day. So I actually was asking some of my rheumatology mentors on like, what is a good way to actually ask this question? And what they suggested are asking really open-ended questions like, what is the best time of day for you? How do your joints feel in the morning versus at the end of the day? And how do you feel getting up and walking in the morning? And then see what the patient says. When you're doing an exam, you should really try to do a complete joint exam in your like 15-minute visit that you have with the patient. There's a video I can send you all from, I think, University of Toronto, where this awesome doctor does a joint exam of all the joints in the arms and legs in like a minute and a half. So if you practice it, you can do it. And if you're limited on time, areas to focus on are palpating all of the joints of the hands and then the MTP joints of the feet. What you're looking for is a doughy, spongy sensation around the joint. So that's what's really specific for synovitis. I know, Rini, 90 seconds for a joint exam. And unlike osteoarthritis, which usually feels kind of bony and firm when you push on an enlarged joint, swelling from synovitis should feel like spongy. And so the more you do it, the more you'll be able to feel it. Loss of valley is helpful too, just visually. So if you look at your MCP joints, which are these joints right here, you have a valley in between your two knuckles, and synovitis kind of flattens that valley out. Joe, that's right. The documentation is the hard part. All right, so we've got a middle-aged patient coming into your office with pain in her hands, left greater than right. Her exam is shown to the right. What is the most likely diagnosis? And this isn't a poll, so just feel free to shout it out or write it in the chat. Anyone brave enough? I didn't give you a lot of information. Okay, I've got some RA, bad DIPs, yeah, bad dips. RA, OA, OA, question mark? Yeah. So the folks who said OA, you are right. Jason, you're absolutely right. This patient has bad looking disease in the DIP joints, which are again, those distal joints. So they're circled for you. So that the distal joint, she actually has nodules called Haberden nodes, which are often seen in osteoarthritis. So I've been actually noticing this ever since I started coming up with this talk, that I have a ton of patients whose like hands I just stare at during the visit, and they often have these nodes on their DIP joints. That's pretty specific for osteoarthritis. She also looks like she has some enlargement, probably firm bony enlargement if we were to push on it, in the PIP joint that's also circled in the right hand. And you can see in the pictograph again that DIP joints are generally affected by OA. RA tends to avoid those. So that's a good way to be able to differentiate. So osteoarthritis, some things to know about it. It's usually asymmetric. You can have one or multiple joints. Morning stiffness can be there, but it should be usually less than like 30 minutes. Pain gets worse with activity. It's worse at the end of the day. And then some exam findings to look for are those Haberden nodules and Bouchard nodes, which are kind of like Haberden nodules, but they're on the PIP joints and then squaring at the base of the thumb. And generally, when you feel the joints, they should feel firm and bony. You can have involvement along the axial skeleton too, especially in weight-bearing joints, so like hips and knees. That's actually one way you can help differentiate from RA is because RA tends to start with the small joints of the hands and the feet and then work its way to the axial skeleton. OA, because of the way that you use these weight-bearing joints, you can just have patients who come in with like, yeah, my hands are fine, but my hips really hurt. Joe says, I've also found that the size of the distal node doesn't always correlate with their reported pain level or dysfunction. Yeah, totally. So actually, there's been studies on radiographic evidence of osteoarthritis too, where you can look to see how bad someone's disease is on radiographic imaging, and there's not necessarily a good correlation with the symptoms they experience. All right, so some photos of Haberden's nodes at the DIPs, Bouchard nodes at the PIPs. You can see the patient on the left with pretty severe squaring of the thumb. I thought this picture was funny because they had like a little right angle picture. On the right, it's a little bit less severe. And then you can see classic osteophyte formation in the X-ray on the right and some joint space narrowing. In comparison, rheumatoid arthritis tends to be symmetric. So people will often come and say, like, both of my hands hurt, same joints often hurt. You have those inflammatory symptoms we talked about, more morning stiffness, pain gets worse with rest rather than activity. You're going to feel for that doughy, spongy swelling. And remember that it starts with the small joints. So look at the hands and feet. And then some characteristic findings you could see are boutonniere deformities or ulnar deviation, but often in early disease, you actually won't see that. And then look for rheumatoid nodules. Those can affect like 30% of patients. So if you see them, it can help you diagnose RA. RA can also affect the axial skeleton, but again, start with the ask if your patient's coming to you and says like I have shoulder pain, is it RA? Try and reorient the patient and think about like ask them more questions about if they've ever had swelling in the hands and feet, and that can help you make the diagnosis. So here's some photos of RA. On the left side, you can see swelling of the MCPs and the second and third PIP joints, but you can see that the DIP joints are spared. Similarly, on the right, you can see that that patient has symmetric swelling of the second and third digits. And then these are some photos of rheumatoid nodules. So you can see them often on the feet and the hands. You can also get them along the forearm or around the elbow. So those are all good places to look for these. And then late rheumatoid arthritis, you can see radial deviation of the hand at the wrist and then ulnar deviation at the MCPs. All right, anyone have a guess as to what this is? I think one thing that I wish I had done more of in residency is look at x-rays of the hands and feet, because I don't feel like I was super comfortable doing that. Any thoughts? Underclassinosis dips look funny. Totally, yes. So you can see this patient has pretty severe joint erosions and osteophyte formation at the DIP joints. So yes, this is pretty typical of osteoarthritis. How about this one? And I should say the one on the left is normal, so don't look at that one. That's just for your comparison. Wrist bones look funny. Yeah, totally. Rat bites. I don't know what that means. Left hand MCPs. Yes. Great. Looks more lucent. Yeah, Totally. Yeah. So, Leah, I think you're pointing out that this patient actually has some osteopenia from RA. Absent pinky finger. Uh, I think it's probably just hard to see. It's there though. Yeah, so the red arrows are also pointing out that it looks like there's some joint erosions along the MCPs. You can see it looks like someone almost took like a bite out of that joint. And then the green, you can see green circles, osteopenia, as Leah was pointing out, which can happen with RA. And then you can see the yellow arrows are pointing to PIP joint space narrowing. And importantly, the DIP joints are spared, so pretty typical of RA. All right, here's an exam. I'm just going to tell you for the sake of time, this is RA. You can see the DIPs are spared here, the PIP joints and PIP joints look inflamed, and the MCPs, you can see that she's got that loss of valley in between her knuckles. Let's talk about serologies. So RF and anti-CCP are the serologies most associated with RA. They're by no means a perfect test. Sensitivity, depending on which study you read, in RF is like anywhere from 26% to like 90%. There's a meta-analysis done recently that suggested it was somewhere around 70%. And then anti-CCP tends to be a little more specific. It's like over 90% in most studies. Generally, you want to get both to help you make the diagnosis. But if they're both absent and your patient seems like they have inflammatory arthritis that fits RA, you can still diagnose them with seronegative RA. And at that point, you'd be asking for rheumatology's help in making that diagnosis, but just know that these are not the end all be all. And then a brief aside to interpreting inflammatory markers. We always order these and they can be really hard to interpret. One thing to know is that ESR varies with age. So a good rule of thumb is that in males, you can divide their age by 2 for the normal range. And then in females, you can add 10 and divide by 2. Again, that's not perfect, but it's just a rule of thumb. It can also be elevated in cancer, infection, pregnancy, diabetes, and it can actually be lower in any diseases where the patient's not producing a lot of fibrinogen. So in particular, patients with severe liver disease. And then CRP tends to be elevated faster and come down faster than ESR does. And it may actually be completely normal in patients with lupus. So it's actually not considered a reliable inflammatory marker in patients with lupus. And then a rule of thumb with CRP is that if it's 2 to 10 times the upper limit of normal, autoimmune is more likely. And if it's more than 50 times the upper limit of normal, infection is more likely. But I will say, I talked to other rheumatologists about this in practice, and they're like, yeah, no, we don't really use that rule. We just have to look at the clinical picture. And if it's high, it helps. We don't look necessarily at the level. All right. And this is just showing what I talked about, where CRP goes up first and comes down faster. ESR tends to lag and come up around 7 days out from the inflammatory inciting event. So in summary, things to look for in RA is symmetry, sparing of the DIP joints, morning stiffness, worse with rest. They may have systemic symptoms. Look for that doughy synovitis on your exam and ask about small joint swelling. All right. So moving on to a 28-year-old patient who's presenting with 2 years of joint pain in the hands. She's morning stiffness greater than 60 minutes and a history of intermittent photosensitive facial rash and fatigue. On exam, bilateral MCPs 2 through 4 are mildly swollen and tender. She's got normal CBC, CMP, and UA. Her ESR is 40. Her CRP is normal. What is the best next diagnostic test that you want to get? Love it. So most people said ANA. Some people said anti-dsDNA. Okay, we'll talk about that. And then someone said RF or anti-CCP. Great. So the right answer is ANA. So this patient has a lot of features concerning for a little bit more than rheumatoid arthritis. So she's got that photosensitive rash, she's got fatigue, she's got inflammatory polyarthritis. And so I think a good next screening test would be an ANA. The dsDNA is a little more specific, but the ANA is probably the next test you want to get because dsDNA is pretty insensitive, and so you're going to miss a lot of patients with lupus if that's the test that you get. It tends to be lupus tends to be female predominant. 95% of patients are ANA positive. In fact, most research criteria actually require ANA positivity in order to be classified as lupus. Patients can get a malar rash, photosensitivity, oral ulcers, alopecia. Most patients have arthralgias with lupus at some point in their disease process, but they may or may not present with inflammatory arthritis. If you see it, Jacquard arthropathy, which is like a reversible joint deformity of the hands, can help clue you in to lupus. And then patients can present with very variable other manifestations that involve multiple organs. So lupus nephritis, serositis, pleuritis, neuropsychiatric symptoms, cytopenias. One thing to know is lupus is actually less associated with actual parenchymal lung disease. So we think about ILD being a manifestation of late RA. Lupus tends to involve the pleura, but actually doesn't cause ILD very much. Joint erosions are also more rare in lupus, so when differentiating it from RA, arthritis tends to be less severe than RA arthritis, and then hand deformities in the disease tend to be reversible, especially early on, whereas with RA, hand deformities are often permanent. And there is a lupus crossover, which we're not going to get into. So this is a video that is not going to play, it looks like. That's okay. So essentially this person, if we were to play it, has this pretty severe deformity of his hand, but when he makes a fist, that deformity actually completely normalizes and looks just like a normal fist, and you'll see him open it back up. It's a NIJM video, you can find it online. It's kind of cool to watch. Okay, so getting back to our case of the ANA. So ANA has high sensitivity. We all know it has very low sensitivity. It can be positive in 15% to, I've actually seen estimates like higher, like 30% of healthy patients, and low titers of an ANA. So when you get an ANA report, it'll be reported as a titer, like 1 to something. And titers that are less than 1 to 80 are very nonspecific. They don't really help you diagnose the disease. Higher titers than that, the higher they are, starts to make it more and more likely that autoimmune disease is happening. And just know that an ANA does not correlate with disease activity. So you cannot use it to diagnose if someone is having a flare. Versus dsDNA, which someone picked, or anti-Smith antibodies are much more specific for lupus, but you can see their sensitivity is quite poor. So you're going to miss a lot of patients if this is what you get without an ANA. And the dsDNA in particular is helpful in correlating with disease activity. So if you have someone with lupus who's coming in and they've got pain, but you're not sure if it's from their lupus, seeing an elevated dsDNA can help you help push you toward that diagnosis. Similarly, C3 and C4 are complement levels, which are often decreased in lupus flares. So it's another way that another strategy you can use to differentiate lupus versus non-lupus pain in a patient who has already been diagnosed. One super important thing is if your patient with lupus comes to you with hip pain, always be thinking about osteonecrosis. Patients with lupus are at high risk of osteonecrosis, which is avascular necrosis of the hips. It can seem like osteoarthritis. Sometimes it presents a little more insidiously. It's often bilateral. It might radiate to the groin, but don't just assume that that's what's happening, especially if they've been on steroids before. They're at high risk of osteonecrosis. All right, so then the last chunk we're going to talk about is spondyloarthritis. Spondyloarthritis is really a series of overlapping syndromes. So it's not one disease. We often talk about psoriatic arthritis as like a single discrete entity, but in reality, there's a lot of crossover with psoriatic arthritis and ankylosing spondylitis and IBD. There's no perfect lab test to diagnose it. Imaging can be super helpful. So if someone's coming in with back pain that seems inflammatory, you can get x-rays to help diagnose SI joint inflammation. Know that they can often be negative in early disease. MRI can be helpful if the x-ray is negative, but you're pretty convinced that the patient has inflammatory spondyloarthritis. And then the HLA-B27 gets talked about a lot. It's not a screening test. Only 5% of patients who actually have HLA-B27 positivity have ankylosing spondylitis, although they are at risk of developing it later in life. And it can be negative in patients with spondyloarthritis, like 15–20% of the time. So things to know about spondyloarthritis. You can have I think what's really important to know is it is very variable. So it's hard to make a concrete diagnosis sometimes, but things to look for are asymmetric, oligo, or polyarthritis. Often lower extremities are involved. The axial skeleton is involved classically in ankylosing spondylitis, but like I said, you can totally have a patient with psoriatic arthritis who is now developing axial involvement because there's so much crossover. Dactylitis and enthesitis, that's sausage digits and inflammation at tendon insertion sites, can happen often with spondyloarthritis. And then uveitis, which is inflammation of the eye of the uvea, is highly associated. If you see psoriatic rashes or nail involvement, think about psoriatic arthritis. Sorry, let me rephrase that. Even without psoriatic arthritis, even without psoriasis rashes, if you see nail pitting or nail involvement and arthritis together, consider psoriatic arthritis as a diagnosis. Bowel inflammation and IBD go along with spondyloarthritis. And when there is peripheral involvement, it often tends to involve the DIP joints. So to summarize a little schema here for you, differentiating osteoarthritis from psoriatic and rheumatoid arthritis, things you're really looking for is, again, inflammatory pain, but also sacroiliitis, dactylitis, enthesitis, and then inflammatory arthritis at the DIP joints. And then things that will help you differentiate that inflammatory back pain from just like your usual mechanical back pain is often that it's being diagnosed earlier, so before age 45, presenting with morning stiffness. And then a symptom that is common is actually awakening from back pain in the early morning. So not that they're having trouble going to sleep, but rather they wake up because they've been resting and their back hasn't been moving for a long time, and now they're getting more and more stiff and having more pain. It tends to improve with exercise. Elevated inflammatory markers and radiographic imaging can be helpful, but it can be negative in early disease. And then you're also going to be looking for other symptoms of spondyloarthritis that we talked about. John, you're saying, yeah, I calculated positive negative likelihood ratios for dsDNA and anti-smooth muscles. For positive results, likelihood ratios are 8 and 25 for those respectively. And for negative results, likelihood ratios are 0.3 and 0.8. So very good if they're positive, especially anti-smooth muscle, but negative results are not that good, totally. Just some pictures of nail involvement. Up to like 80 to 90% of patients with psoriatic arthritis have nail involvement, and about like 50 to 60% of patients with psoriasis without any arthritis have nail involvement. So you can see at the top left some nail pitting, top right onycholysis of the nail, and then bottom right, that's a picture of subungual hyperkeratosis where you have deposition under the nail bed. And then the bottom right is splinter hemorrhages. So those are things to look for on exam. And the DIP joints in psoriatic arthritis can often get, or can sometimes get eroded away to the point where they actually look like a sharpened pencil, so called the pencil in cup deformity. This can be seen with rheumatoid arthritis as well. So it's not specific for psoriatic, but often associated. And then really severe disease. So a patient who's had psoriatic arthritis for like 10+ years, can develop arthritis mutilans, which is severe erosion of the bones to the point where you actually lose your bony support and the finger skin becomes loose and starts like telescoping in on itself. All right, so last few minutes, I just want to review what you can do in a primary care doctor's office for patients who are immunosuppressed and have autoimmune disease. So patients on immunosuppressants, before you start them on immunosuppressants, before you refer them to to rheumatology, at that first appointment, get a TB screen, a Hep B and C screen, and make sure you get it with Hep B core antibodies, and then an HIV screen. Vaccines are super important because your patient is immunosuppressed. A couple differences to know is the pneumococcal vaccine should be given at age 19, so quite early, and the Shingrix vaccine should be given at age 18. If your patient is on biologics or JAK inhibitors like tofacitinib, they should not get any live vaccines. But if they're on a traditional DMARD like hydroxychloroquine, methotrexate, sulfasalazine, they're totally okay for both live and killed vaccines. And then if your patient is on hydroxychloroquine for any reason, make sure that they're getting annual eye exams. That can be often missed. And then osteoporosis screening is also super important. Anyone over the age of 40 years who's taking prednisone 2.5 milligrams daily for 3 or more months should get a DEXA scan. So that's actually a really low dose. I mean, how many patients do you know who are like not able to wean off that last 5 milligrams of prednisone and they've kind of been on it for months or years and they just keep going back on it? I have a ton of patients who I've met like that, and those patients should definitely be getting DEXA scans. For anyone under 40 who's taking glucocorticoids and has a history of a fragility fracture or known risk factors for fracture, should also be screened by DEXA scan. And then for anyone with RA who makes it to age 50 and hasn't gotten a DEXA scan should also get a DEXA scan. All the patients we talked about today are at higher cardiovascular risk than the average population. There's not a guideline that I could find on like starting them on early statin therapy or early medications. The EULAR, which is the European the European Alliance of Associations for Rheumatology, I believe. They changed their name a few years ago, and it's like quite a mouthful. Recommends screening people for cardiovascular disease every 5 years. They used to recommend yearly, but in 2016, the data was showing that there's not really a benefit to checking them that often. Turns out people's cardiovascular risk doesn't change all that much year to year. So now it's every 5 years. And just note that a lot of these inflammatory reasons for developing early cardiovascular disease and cardiovascular death are not captured in our traditional ASCVD risk scoring model. So it's something that you kind of need to talk about with the patient and make shared decisions about if they're sort of like borderline risk. And then unfortunately, patients with inflammatory arthritis have high rates of depression. There was a 2022 study in the Academic Journal of CL Psychiatry that cited that psoriatic arthritis patients had about 50% thoughts of suicide, or 50% of them had contemplated suicide at some point. This can be a really debilitating illness for people to have, and it's really important as a primary care doctor that you're doing regular mental health screenings and helping to improve their quality of life as much as you can. So take-home points, there's a lot of ways to approach joint pain. Just try to pick one and then use it every time. There's no perfect diagnostic criteria for most chronic inflammatory arthritis, and so it is okay to be upfront about that with your patient. If you see someone who has a lot of symptoms of inflammatory arthritis, they don't fit any perfect disease process, or maybe they have just kind of the beginnings of a disease process, it is okay to refer them to rheumatology. They might even be started on treatment, and then share with them that sometimes it takes a few years before we can attach a clear name to this illness because there's just so much overlap and uncertainty. And then early referral, treatment, and vigilant monitoring can prevent severe joint deformities and decrease complications. And you can help do that by screening folks for cardiovascular disease, mental illness, et cetera. Cool. I just want to acknowledge Dr. Thomason and Dr. Weisham for all of their input. Any questions? Cool.
I think we're stunned with your brilliance. This was amazing.
Thanks, guys.
Yeah, the thank yous are coming in.
I have one question. I know spondyloarthritis is actually like shockingly common. Like they've done these studies and like people who seek chiropractic care. Um, and I certainly think about it and get x-rays and the x-rays are normal and I'm like, it's fine. Should I be in folks with like convincing stories? Should I be sending all these people to rheumatology? Like what is the next step for that?
Yeah, I think it's fair. Like if they're bringing in a pretty convincing story of inflammatory arthritis, oftentimes spondyloarthritis don't get diagnosed until much later because early imaging is all negative. I think it's worth at least sending an e-consult if you have that question, and they can help like guide you in terms of who needs to be seen. But again, it's also okay to kind of share that with the patient, be like, you have some symptoms of this, you may be at risk of developing it. And we're gonna work on that, maybe get some expert advice.
Any other questions? Well, what a great mix of presentations today. Every one of you, such a great job, and really appreciate all the learning that you helped us with today. And with that, you finished exactly 1 minute early, even despite the limitations. And so thank you all for that. And we'll wrap it up.